Good afternoon, dear audience. My name is Katalin Lugosi. I am a neurologist in Bajcsy Hospital, and my PhD topic is cognitive impairment in multiple sclerosis. My supervisor is Zsolt Mezei at Department of Neurology, Semmelweis University, and our vision is to establish the basis for a uniform set of criteria in the assessment of MS cognition. And our mission is to assist in planning further researches and selecting the most appropriate neurorehabilitation care in MS cognition. And to achieve these goals, we have two main topics, the cognitive impairment in different subtypes of multiple sclerosis. The aim is to understand different cognitive impairment pattern in MS with this. And the second one is also a meta-analysis, correlation between patient characteristics and cognitive screening test results in relapsing remitting multiple sclerosis. About the first project, the background, cognition. Cognition contains 5 main and plus 1 the social cognition, so 5 main cognitive domains, the memory, executive function, attention, language, and visuospatial perception. And all of these are measured by different neuropsychological tests, and all of them called BRBM battery, the brief repeatable battery of neuropsychological tests. And MS is a neuroinflammatory disease with different subtypes, like clinically isolated syndrome, relapsing remitting multiple sclerosis, primary and secondary progressive multiple sclerosis. And the problem is there is a lack of comprehensive up-to-date analysis in each different subtypes of MS with regard to the main cognitive domain impairment. And there is no standard consensus on the definition of cognitive impairment in MS, so different cognitive tests and cutoff values used in the literature. Our clinical question is, what is the prevalence of cognitive domains impairment in different subtypes of MS, measured by these selected neuropsychological tests? And our hypothesis was the progressive forms of MS have the highest prevalence and information processing speed is the most affected cognitive domain in RLMS. This is an observation in everyday clinical practice. Here you can see the systematic search and search key and the flowchart of selection. We started with more than 10,000 articles, and finally we have 48 eligible articles, 40 for the meta-analysis and plus 8 for the systematic review part. Results. Here you can see a summary plot of cognitive domains impairment prevalences rates across subtests of BRBM battery. You can see here the prevalence rates and different neuropsychological tests and different subtypes of MS at 1.5 standard deviation. It means that the test scores are equal or below than 1.5 standard deviation of the normative expectations. And at 2.0 standard deviation below the normative values, and 5th percentile below the normative values, because these are the 3 most frequent cutoff values defining cognitive impairment in MS. Main findings based on these results: certain degree of impairment can be observed regarding all the cognitive domains within each subtypes. And the most pronounced, the progressive forms, as we can observe in a clinical practice. The exception is the verbal fluency, which is highest degree in PPMS, and the clinically isolated syndrome, which is an early form of MS, is less severely affected among all subtypes. Information processing speed and attention affects a quarter or 1/3 of relapsing remitting multiple sclerosis. And the information processing speed was more markedly impaired in the primary progressive group compared to the relapsing remitting form. So we can declare that more severe cognitive decline can be predicted in progressive forms of MS, and the IPS is and the attention domain and working memory are the most affected cognitive domains early in the course of the disease. And we suggest that neuropsychological test batteries are required for detailed mapping of cognitive impairment in MS. And based on our findings, the 1.5 standard deviations below the age and education mean was the most frequent threshold defined as pathological in the studies. And we give a consideration. Consideration should be given to the recommended use of this value in further cognitive assessment. So as you can remember, my vision, our vision, that to establish a basis for a uniform set of criteria in the assessment of MS cognition seems to be completed with this meta-analysis. We are at the internal review part. The target journal is a JAMA neurology implications. Uniform criteria, with uniform criteria, it helps to give personalized and domain-specific cognitive neurorehabilitation programs. And in the research part, uniform criteria helps facilitating the comparability of future studies and further researches. Strength of our study is that we use the same cognitive tests and separated cutoff values, and which was not in the case in previous meta-analysis on similar topics. And we were the first to include clinically isolated patients in our investigation. And the limitations are we disregarded the variation in clinical and demographic parameters underlying the results because there was no enough data for this. And the BRBM battery, honestly, for executive function is underrepresented in this battery. So it's a limitation. About the second project, correlation between patients' characteristics and cognitive screening test results in relapsing remitting multiple sclerosis. The background is, in everyday clinical practice, the SDMT test, symbol digit modalities test, is recommended for a cognitive screening in MS. If you remember this figure, it measures the information processing speed and attention domain. And because SDMT measures decline of this domain as early signs of cognitive impairment in MS, so that's why this is a cognitive screening test. But the extent to which clinical and demographic parameters influence the test scores is not well understood, although identifying these associations is essential to accurately assess test results and to highlight patients, and this is the most important, to highlight patients at risk with significant factors affecting the test results. Our question is, do different clinical and demographic parameters affect the results of the SDMT cognitive screening test? Population is the same, MS population, but just only the relapsing remitting form. And we will measure the different clinical and demographic parameters in correlation of, so the outcome will be the SDMT raw scores. Systematic search and search key you can see here, and we are at the at this part at the Prospero registration now. So for summary, our aims are to give detailed mapping of cognitive impairment in multiple sclerosis, and to answer the question, how does the cognitive screening test correlate to clinical and demographic parameters? We have two main meta-analyses. Thank you for your attention.
Congratulations, Kati, on the progress. I have a quite non-specific question for you, if I may. I'm wondering, as a result of your work, what kind of changes in the clinical practice, day-to-day clinical practice, do you imagine in a neurological institute? What approach will change, or how will we change our perspective on how to treat people with MS?
Thank you for your question. I would highlight patient in everyday clinical practice, because if I know, for example, in relapsing remitting form, which is the most frequent form of MS, has the highest prevalence rates of information processing speed domain, I would give more attention to this patient and highlight him or her, and to give more the neurorehabilitation programs and special neurorehabilitation programs based on this. So the main goal would be to improve for example, the information processing speed abilities. Or in PPMS group, if I have a PPMS patient, a primary progressive patient, and I know that verbal fluency is very highly affected in this subtype, I would pay attention and I can give her or him a special language therapist, for example, because I know I have a PPMS patient and he or she needs more attention in this domain, and yes, maybe. Because in MS care, so very frequently we forget these cognitive problems and cognitive abilities, and we mainly focus on the movement problems and the visual problems, but we very frequently ignore the cognitive problems of our patients.
Thank you. It was a really nice presentation. I just simply want to ask whether we should implement this knowledge to the Hungarian financial system, whether because of decline in cognitive function, a patient may have further medical help, yes, which is technically paid.
Yes, it's a problem in our country, but I think in other countries it's also a problem because there we have not enough language therapeutists, yes, and neurorehabilitation specialists. It's a problem, but I think it's a worldwide problem.
I would like to ask you, which is the life-threatening part or problem with MS? Cognitive decline or moving, eating problems? Which is worse?
I think each of them. Or so we must care and must treat patients in their complexity, or in their so not just focusing on the movement problems, but also on the other problems like cognitive and psychological problems, and I would like to highlight this part of...
The question was, which is more dangerous?
Dangerous, the life.
Yes, I know. I don't know which is more dangerous, because I think cognitive problems are as dangerous as the movement problems.
Thank you very much.